MSU crystal deposition. What is MSU? Monosodium urate. Monosodium urate. Now we all know, I think you and me, we all know, uric acid is a byproduct of metabolism of purines, right? So purine metabolism, now you will get questions from biochem also, so you must know about this. Purine metabolism leads to uric acid formation. One interesting thing is serum uric acid in a patient presenting with gout or swelling in the joint or inflammation of the joint doesn't necessarily have to be raised. It can be normal, it can be low, it can be high. Please remember this. This is something that they will ask you, that they will give you statements, what is true statement, and one of the statement will be that serum uric acid of the patient is always high. So please don't mark that as a true statement. Okay, so what are the joints that are involved in gout first? So, pardon my drawing, 1, 2, 3, 4, pardon my drawing. But if we talk about these joints here, this is a foot. Looks like a swollen foot, but okay, this is the foot. So, the most important joint or the most commonly involved joint is the MTP of the first toe, metatarsophalangeal joint of the first toe or the great toe. And the second is the ankle. Third are the tarsal joints. And then there can be involvement of the knee. So MTP of first toe, followed by ankle, followed by tarsal joints, followed by knee. Okay, now what are the precipitating factors that can lead to this joint swelling or inflammation? Since it is a crystal deposition, it is not happening all the time, right? There are certain factors that are involved in this, certain precipitating factors which actually precipitate the deposition of these uric acid crystals into the joint. And these crystals into the joint lead to joint inflammation, because obviously anything in the body that comes from outside, the body tries to react. So the joint reacts. And that leads to inflammation, that leads to swelling, that leads to pain. You know, the features of inflammation are pain and swelling. So that is what happens. So that is why it presents with joint pain and swelling. But then what are the precipitating factors, right? What are the precipitating factors? We need to know this. This is something that is asked in the exam. The precipitating factors of gout are trauma, okay, any surgery, okay, alcohol, a vascular event like a stroke or an MI, and even hypouricemic treatment. So you see a patient having uric acid of 8, not having any joint inflammation, not having any signs and symptoms of gout, and you start the patient on febuxostat or allopurinol, and the patient ends up to you with gout or with the joint swelling in the foot. So hypouricemic treatment can also precipitate gout. Right now, and why is that so? Because whenever we give hypouricemic treatment, the uric acid levels in blood go down drastically and very rapidly. And when they go down, the crystals that have already formed may get deposited. So it's a precipitating factor. It can precipitate the deposition of crystals into the joint. Just high uric acid level in the blood doesn't lead to gout. That is not the only risk factor for gout. But that is the most common one. Now, if we talk about synovial fluid, what are the findings in the synovial fluid in a patient of gout? This is a question for your INICET or your NEET. This is a question for INICET or NEET. So the synovial fluid findings will be WBC more than 2000 per microliter, MSU crystals on needle aspiration of fluid. So fluid aspiration, if you take out a fluid aspirate, if you tap the joint in the fluid, you can find MSU crystals. So this is about the synovial fluid. Now, if we talk about blood levels, then serum uric acid can be normal or can be normal, can be high, can be low. Then if we talk about 24-hour urine uric acid, yes, so this is important, 24-hour uric acid levels in urine. If it exceeds more than 800 milligram, this is very specific for gout. If it exceeds more than 800 milligram, this is very specific for gout. It can also lead to deposition of uric acid in the kidneys and thus leading to kidney stones, right? And then if you do an X-ray of the joint, what will you find? In the X-ray of the joint, you can find cystic changes and you can find erosions. Can you tell me one arthritis that doesn't have erosive arthritis or doesn't have erosions on X-ray? I think many of you have guessed it already. It's SLE, right? So cystic changes and then erosions with sclerotic margins. Erosions with sclerotic margins. Okay, so this is one thing. Then very important thing, what is the treatment of gout? Now treatment of gout is something that everybody asks in the exam, or the most important question from gout in the exam. Okay. All right. I hope you all have taken a note of all of this. Gout is not a very big topic. Okay. Study smartly. If you study smartly, you will be more efficient. So be smart as a medico. Be efficient. Use less time for more work. Right, bachas? So if it is an acute gout, of course, and NSAIDs, steroids, and colchicine are the option. Now, colchicine dose is 0.6 milligram TDS. In case it becomes chronic or it is acute and having hyperuricemia, raise serum uric acid more than 9 milligram per deciliter. आर टारगेट इज, हमारा टारगेट क्या होता है? यूरिक एसिड जब बढ़ता है तो हमारा टारगेट लेवल क्या है उसको कम करने का? टारगेट लेवल इज 5 to 6 milligram per deciliter. And how do we achieve that target? How do we achieve that target? So either you make the kidneys excrete more of uric acid, okay? So uricosuric agents, right? So we have two uricosuric agents, or you make the metabolism, you interfere with the metabolism of purine and lead to less uric acid formation. So xanthine oxidase inhibitors, this is one enzyme that is involved in purine metabolism and leads to uric acid formation. So xanthine oxidase inhibitors, XO inhibitors. So we have 1 and 2 of these. And then there is a new enzyme, that is uricase. So a pegylated uricase, as the name suggests, it breaks down uric acid. So pegylated uricase. So these are the medicine. Let's learn their names. So total of 5 medications, right? 2 uricosuric agents, 2 xanthine oxidase inhibitors, 1 pegylated uricase. So uricosuric agent number 1, I think we have all heard about it, probenecid. Probenecid, yes. The dose here is 250 milligram BD, and we can go up to max 3 grams in a day. We can go up to max 3 grams in a day. Note this down. Probenecid is contraindicated in patients with creat level of more than 2 beta. So remember that. The next new uricosuric agent is lasinurad. Lasinurad, and the dose is 200 milligram OD once a day. 200 milligram once a day. Then coming to xanthine oxidase inhibitors, allopurinol, we all know about it, we all have heard about it, allopurinol. The dose is 100 milligram once a day, can go up to 800 milligram in the day. So 100 milligram once a day to 800 milligram once a day. That is all about allopurinol. The next xanthine oxidase inhibitor is febuxostat. इसके नाम में xanthine oxidase आ रहा है, XO. So easy to remember. Febuxostat. So xanthine oxidase stat, something that pauses or inhibits xanthine oxidase, right? So febuxostat. So आधी दवाइयों के तो नाम में ही उनका mechanism है. Half of the medications have the mechanism in their name itself. Please read pharma like you are enjoying it. and then you will remember all the medicines and everything. It's not very difficult. And it was the most interesting part of MBBS, pharmacology, knowing about medications, because that is the one thing that you will need your whole life. Nobody in these times like today, nobody is going to ask me the pathogenesis of migraine, but they are going to ask me the medicines for migraine, right? Nobody is going to ask me the pathogenesis of SLE, which interleukins are involved in SLE. But people will ask me, what is the treatment of SLE? What are the classification of lupus nephritis? Have you screened for lupus nephritis or not? So these are important things. So pharma is important. Pharma stays with you for lifelong. So please read that carefully. It is not only for your exam, but also for your practice, for your future practice, right? So pharma is important, very interesting also. Say, thirdly, pegylated uricase. This is also something new. Pegloticase, नाम से पता चल रहा है, pegloticase, uricase, right? Now this is the only IV medicine. So what is the question that they ask? So 8 milligram IV every 2 weeks. So question number one, the question is regarding the mechanism of action. So for example, probenecid is a uricosuric agent. You should know lasinurad is a uricosuric agent. You should know that allopurinol is a xanthine oxidase inhibitor. Febuxostat is a xanthine oxidase inhibitor. Pegloticase is a uricase, a pegylated uricase. You should know that this is the only IV medicine among uric acid lowering agents. You should know the maximum dose of probenecid, 3 grams. You should know that it is contraindicated in CKD patients or patients with creato more than 2. You should know the maximum dose of allopurinol, 800 milligram, and from 880 is very easy to remember, and then 8 is very easy to remember. So 800 allopurinol, 80 febuxostat, 8 pegloticase, very easy to remember doses, very easy to remember topic. Okay, so this is all about gout. Uh, take a break of 2 minutes and come back. And we will start with another topic like Behcet. Let's read about Behcet also while we have time. Time is of essence. If you ask me, Dr. Priyanka, what is the most important thing in life? I would say time. It's not money, it's not your family, it's nothing, it's time. Right? If you manage your time well, your family, friends, your personal life, professional life, everything is settled accordingly. Right? So let's read about Behcet. Take a sip of water. I'll take a sip of my coffee and we'll start in 2 minutes. Okay. I've already, so these are my notes and I've already um, put these across on the site, the bio that I have, the website and the platform where you got the videos from. I have the notes also there. So you can purchase the notes from there. It's at a very nominal rate. I'm going to keep on adding chapters into there. So I think today I will complete rheumatology lectures and then we'll start with hematology, right? So let's complete rheumat today. So let's go ahead with Behcet. Now I think we all know that Behcet is it is an autoimmune vasculitis syndrome, right? So it is not a typical vasculitis because it is actually systemic perivasculitis, but it is an autoimmune disorder, right? So number one thing to remember about Behcet is autoimmune. Second, systemic perivasculitis syndrome. Third, male and female ratio is same, but males have more severe disease. Okay. Then, what are the diagnostic criteria for Behcet? So in rheumatology, as you know, diagnostic criteria takes importance, right? Diagnostic criteria for RA, SLE, ankylosing spondylitis, psoriatic arthritis, Reiter's arthritis, reactive arthritis, Behcet, these are all very important. So the diagnostic criteria for Behcet is recurrent oral ulceration plus any two of following, two or more of following. So any two of following. What is the following? So there is a mnemonic for this. And what is the mnemonic? The mnemonic for this is positron. Positron. Okay. So P, O, S and R. P, O, S and R. Positron. You can remember it like positron. So P is positive pathergy test. Positive pathergy test. O is ocular lesions. See, we said oral ulcers. We did not talk about ocular lesions. So ocular lesions. S is skin lesions. And R is recurrent genital ulceration. Right? So we know that mouth is one thing that is, see, this is a patient of Behcet. Better pardon my drawing. This is something I really suck at, and I know about it. You don't have to tell me. Okay, so if this is the patient of Behcet, looks like a patient of Bell's palsy. All right. So one is mouth, oral ulceration. One is ocular involvement, eye involvement. Third is skin involvement, and fourth is the genital involvement, right? So genital ulcers. So oral ulcers, genital ulcers, ocular lesions and skin lesions. These are the main things, right? And a pathergy test. So skin का उसमें हमारा pathergy test भी आता है. So these are the, please try to remember this figure. I know it's not very beautiful, but I think that is what makes it more memorable, right? So try to remember this and you'll remember the 4 organs that are involved. Every 5 years, one question comes from Behcet's. That has been the approach of the examiners. Every 5 years, हम एक छोटा topic में से will give a question. So Behcet. Now, the next important thing about it to know about this is what exactly are these lesions that we are talking about, and are there any characteristic features for these lesions? So, if we go from head to toe, one is oral ulcer, we have eye, NEUROBEHCET. So, this is all of head and face involving all of head and face. Then we have skin involvement. Then we have genitalia involvement. Right, and then we have the joint involvement, because of course we are talking about rheumatology and we're talking about joints. So yes, so these are the important things about Behcet. Now oral ulcers, important thing, painful, remember this, the oral ulcers in SLE are painless. Painful oral ulcers, Behcet. Less than 10 mm size in 85% of patients. 85% of cases have less than 10 mm in size. All the oral ulcers are aphthous and they have a yellow necrotic base. Yellow necrotic base. And they take approximately 1 to 2 weeks to subside on steroid or immunosuppression on treatment, right? So they take 1 to 2 weeks to subside even on treatment. Talking about eye. So bilateral panuveitis. Okay. So uveitis is a good feature, is a common feature in certain autoimmune disorders like ankylosing spondylitis, Behcet, but uveitis is not a feature in rheumatoid arthritis. Okay, uveitis is not a feature in rheumatoid arthritis, but uveitis is a feature in Behcet. If we talk about NEUROBEHCET, so 5 to 10% cases of total of Behcet are having NEUROBEHCET, present with neuro lesions. And the most common site in CNS involvement is a brainstem involvement, and the second is cerebral veins. So cerebral venous thrombosis beta, cerebral venous thrombosis we check the patient, examine the patient for oral ulcerations, for genital ulcerations, right? Because that is one of the common presentation of neurobeshet. A young patient with CVT, check for Behcet. Now skin, 80% patients have skin lesions. 80% patients have skin lesions. And what are the lesions exactly? So because it is a vasculitis, a systemic perivasculitis, erythema nodosum can be a finding, or the vasculitis lesions, the vasculitic rash, which is a non-blanchable rash. So vasculitic rash, erythema nodosum, folliculitis. These are important features. Pathology test is a skin test that is positive. And by pathology test, we mean a non-specific skin inflammatory reaction to scratch or trauma or to saline injection. So subcutaneous or intradermal, mostly intradermal. So if you inject normal saline intradermally and that leads to an inflammatory response over that area, we say that pathology test is positive and it is one of the diagnostic criteria for Behcet. If we talk about joint non-deformity arthritis, we call it non-deformity arthritis. The arthritis with deformities is usually in rheumatoid arthritis involving the peripheral joints and ankylosing spondylitis involving the spine, the axial joints. If we talk about genitals, so there are painful genital ulcers. So there are painful ulcers, scrotal or vulval ulcers mainly, epididymitis, glans, penis or urethra not involved. Why is this important? This is important because these are the things that are involved in sexually transmitted diseases. Glans, penis, and urethra are usually involved in syphilis or venereal diseases, chlamydia, and all. But in Behcet, if there are genital lesions, usually glans, penis, and urethra are spared. So you should know this. So, what are the important points to remember here on this page? One is that the oral ulcers are painful. Second is less than 10 mm. Third is they take time to subside even on treatment. Uveitis is a feature of Behcet. NeuroBehcet, the most common site is brainstem. Skin involvement is the most common involvement. And pathology test is positive in Behcet. Genital ulcers, glans, penis, and urethra are not involved. Joints arthritis happens but doesn't lead to any deformities. Now, very important to remember that it is associated with HLA-B51. Okay, now why is this important? Because this is a very specific marker. This is a very specific marker for Behcet, but because it is not available everywhere and not very, um, what can we say, not very sensitive, not positive and all, it is not in the diagnostic criteria, not there in the diagnostic criteria. Okay, so that's all about Behcet. If we talk about treatment, then like all the other autoimmune disorders, immunosuppression. So steroids and then followed by steroid sparing agent. Steroid sparing agent can be MMF, azathioprine, cyclophosphamide, methotrexate. Usually MMF and azathioprine are the medicines of choice. So this is all about Behcet. Try to remember all of this. These are the most important questions asked from this topic. Okay, and let's talk about ankylosing spondylitis in our next lecture. All the best. Bye bye. Take care.